I'm going to go through some information on Alzheimer's disease medications, and we're really going to be looking at those medications that have been more recently approved in the last couple of years. And I will start off by saying that this is not my area of expertise, but it is an area that is of interest to me, and I have really enjoyed learning and gathering information on this topic to present it to you today. So I welcome you to ask questions, and if I do not have the answer for you today, we will work to get those answers to you through the GWeb office as well. So I thought we would just start by having a conversation, and perhaps you'll want to unmute yourself, or perhaps you'll want to make a comment in the chat, and I'm just going to open up the chat so that it's here on the side in case you decide you'd like to do that. And my question is do you think dementia is a normal part of aging? So I'll give you a minute to think about that. So I see lots of no's. And you know, this is very interesting, I think, because I wonder if we asked our patients if dementia was a normal part of aging, if they would have different responses. And so I see we had one that's maybe a little controversial. So I think when you look at information that is available, and I'm going to go ahead and close this meeting chat for a minute so that we can see the screen a little more fully. The National Institutes on Aging defines dementia as, quote, the loss of cognitive functioning, thinking, remembering, and reasoning to such an extent that it interferes with a person's daily life and activities. And it also seems that there are descriptions on what would be forgetfulness versus what would be mild cognitive impairment versus dementia as well. And so a lot of these are maybe hard to differentiate, maybe differentiate between in some instances, whether someone has mild cognitive impairment or very mild dementia as well. But it does warrant us considering like what would be normal, and for helping our patients to understand what would be normal aging and forgetfulness perhaps that is a part of normal aging, and at what point would we be wanting to catch or to intervene in something that is beyond what would be considered normal aging forgetfulness, because that's really where these new medications for Alzheimer's disease are targeting. They're targeting patients who have mild cognitive impairment, and they're targeting patients who have mild Alzheimer's disease. And so right now, I don't know that we have good resources in place to help catch early signs of Alzheimer's disease or early signs of cognitive impairment. So the National Institute on Aging has some great infographics, and I put one of them in this slide for you to look at as well. These are really great that you could use with patients if you wanted to talk about the differences. They also have a video resource available that's called, or that's titled, What is Dementia? And so understanding different types of dementia is the title of this infographic. And the National Institute on Aging actually encourages individuals to share this image on the right hand that I have posted here to social media and to use their hashtag so that they can try to help people understand what dementia is and what the different types of dementia are. So Alzheimer's disease is the most common type of dementia. Kind of going into this a little more in depth, you can see from what's happening in the brain in this picture right here. There are abnormal deposits of proteins that form amyloid plaques, and these will be important for the medications that we talk about today, and tau tangles throughout the brain. There are signs of mild, moderate, and severe Alzheimer's listed. So mild would be wandering and getting lost, repeating questions. Moderate would be problems recognizing friends and family or impulsive behavior, and severe would be not being able to communicate. The typical age of diagnosis is usually mid-60s and above, although there are some cases where mid-30s to 60s have been diagnosed as well. And then as far as symptoms go, symptoms can be similar among different types of dementia, as outlined in this infographic. And some people have more than one form of dementia, which can make an accurate diagnosis difficult. And so there's some more information here, how symptoms aren't the same necessarily from person to person. And it really does take a physical exam, a complete medical history, even looking at medications, because there are many medications that can cause cognitive impairment. And so having a pharmacist involved in looking at medications that are potentially inappropriate that might be contributing to symptoms can be part of the workup or diagnosis, workup for a diagnosis or exclusion of Alzheimer's disease. So the Alzheimer's Association has a number of statistics that are posted, and I printed these and inserted them directly from the website from the Alzheimer's Association. And right now, an estimated 6.9 million Americans 65 and older are living with Alzheimer's, and 73% are age 75 and older. There's also some information about other demographics listed, but I think the one that I highlighted here is also important because as our population continues to age, we'll see that, quote, by 2050, the number of people aged 65 and older with Alzheimer's may grow to a projected 12.7 million, barring the development of medical breakthroughs to prevent or cure Alzheimer's disease, end quote. And so that brings us to the U.S. Department of Health and Human Services National Plan to Address Alzheimer's Disease. And in 2011, the National Alzheimer Project Act was signed into law. And I have this first paragraph that's in the National Plan to Address Alzheimer's Disease, the 2023 update, inserted here for you. And one of the things I highlighted has been part of this plan for quite some time. Accelerate the development of treatments that would prevent, halt, or reverse the course of Alzheimer's disease. So there has been interest in the area of developing new medications that could potentially treat or prevent, cure Alzheimer's disease, but there hasn't been a lot that has happened until about 2021. And you'll see what has changed in the landscape of medications here in just a moment. But really, this is something that continues to be a priority, and I think we should continue to expect that we will see a lot of money invested into research and development, perhaps, of these new medications or of potential targets for medications. So let's continue our conversation. Can you recall in your practice area, from your perspective, the last time there was, quote, the development of medical breakthroughs to prevent or cure Alzheimer's disease? Do you remember the last time something happened? And you can use the chat. And so it is interesting what we have seen for medications has not been a lot in the past. And there have been some things very recently that have been coming through, and I do think we'll see more. But I was thinking back to my practice and my experience, and I remember the last time a medication was approved prior to 2021 was when I was in my third year of pharmacy school. And so if we look at pharmacologic treatments for Alzheimer's disease in a timeline, we can see that the cholinesterase inhibitors, we first saw them come into play around 1997, and then the N-methyl D aspartate or NMDA receptor antagonists in 2003. but then nothing between 2003 and 2021. So it has really been a long time. And in 2021, there was an anti-amyloid monoclonal antibody, and that is the new class of medications that we are starting to see a few different studies on and a couple of different approvals. And this is targeting those amyloid plaques in the brain. And so this is the group that we're going to talk a little bit about today. And interestingly enough, even since the topics were set last summer, there have been a couple of changes, and one that we expected that hasn't quite been realized yet. So I'll start with the things that are currently available. So we have the acetylcholinesterase inhibitors, diazepam, rivastigmine, and then galantamine. And these are all FDA approved. You can see that some of them are for mild and moderate Alzheimer's disease. Some are for moderate to severe Alzheimer's disease. Some are for all three, and it can differ with dosage forms. And then we have, so these were in 1997. Then we have the N-methyl D-aspartate, an NMDA receptor antagonist, and this is memantine. And that was approved in 2003 for moderate to severe Alzheimer's disease. Now, none of these medications cure Alzheimer's disease. They simply help patients to maintain function for a longer period of time, but it doesn't prevent or really delay Alzheimer's disease from developing. And this is the new class. And so there are two medications currently that are FDA approved, but we'll talk about aducanumab a little bit here in a moment as well, and it's had some changes more recently as well. And then lecanemab. So aducanumab is FDA approved for mild cognitive impairment or mild dementia. So this is interesting. You know, it's targeting very early in the disease process itself. So even with mild cognitive impairment before a diagnosis of mild dementia has been made or mild dementia. And the same is true for lecanemab. They both have a black box warning for amyloid-related imaging abnormalities, and this is one of the most severe adverse reactions that this medication has. And so we can see ARIAs with edema or ARIAs with hemosiderin deposition. And we also have evidence that shows that those individuals who have ApoE4 homozygotes, so genetic, have this genetic predisposition or are homozygotes at this level, have a higher incidence of ARIA. So it's very important for individuals to know their status and to know if they are ApoE4 homozygotes. So here are the black box warnings a little more closely. So those who are ApoE4 homozygotes do have a higher incidence of ARIA, and that includes symptomatic and serious ARIA. So when you look at if a patient develops an ARIA, they will look at whether it's symptomatic or asymptomatic, and then look at kind of what's happening clinically and make some decisions on whether to hold therapy or whether to continue therapy. And our prescribing information has some specific outlines for what to do in those scenarios. But they both have the same black box warning. So this is something that is not really in a guideline, but there have been some articles that have been put forth, and this one was by the American Academy of Neurology. And this is an emerging issue in neurology article. And so they tried to kind of gather the information and synthesize it in this article. And this was published in 2023. So they have tried to kind of help guide as this information becomes available, but all of these agents are relatively new. And in fact, in one place, and I can't remember where it was that I read now, they were talking and kind of comparing the emergence of this class of medications, kind of like some of the early medications that were used in HIV and AIDS, where what we started with kind of evolved pretty quickly, and then that was not necessarily what we currently use now. And so in some cases, some of these medications that are approved may be a stepping stone, and they may not be as good as some of the medications that will come as a result of what we're learning from these medications as well. So aducanumab was very controversial in its approval. And so perhaps you remember hearing about this in 2021, but this medication, this monoclonal antibody that was the first in the class, the first Alzheimer's medication to be brought forth since 2003, received accelerated approval from the FDA in 2021, but they were uncertain if the medication itself had any clinical benefit. So it was approved. In that accelerated approval process, you can have a medication can be approved if there is expected to be some sort of clinical benefit based upon biomarkers. And so because this medication decreased amyloid in the brain, they thought that it would be clinically beneficial. And it didn't really take off. And in fact, there were 2 phase 3 trials that were done for this medication, and one of them showed no benefit, and the other one showed benefit at a higher dose. But that higher dose also increases once those ARIA adverse effects can occur more frequently with higher doses. And so as of January, it was announced that aducanumab will no longer be available as a prescription by November 1st. And actually, as of May 1st, all patients that were enrolled in a trial that was used to the medication. And so this is quoted from the Alzheimer's disease Association. According to Biogen, that medication will be discontinued in order for the company to, quote, reprioritize its resources in Alzheimer's disease. And it said that it's not being discontinued for reasons related to safety or efficacy, but it is interesting to see that they didn't really end up with trials that showed, or evidence that showed, significant efficacy for this medication. So this will no longer be available. So right now, if you were to look it up, you'll see that it's available and FDA approved, but shortly it will not be available any longer. The one that remains that will be available or is available is lecanemab. And this was approved by the FDA in 2023, and they used the traditional route, and it was based upon data in part from the phase 3 trial Clarity AD, which I have a picture of the New England Journal of Medicine article that it was that had this. And they actually found that those ARIA amyloid-related imaging abnormalities were a little bit less were less in lecanemab as compared to the aducanumab. And so it's interesting to recognize too that we may see, as there are additional monoclonal antibodies that are brought forth, that there will be differences between medications in the same class for adverse effects. And so that will be important for us to try to understand and to be able to choose which therapy might be best for a patient in a given situation. But this monoclonal antibody did have some evidence that showed that it was able to improve Alzheimer's disease. And so there is some specific information that is available for lecanemab, and this is just some of the prescribing information, and I've taken this right from the prescribing information that's posted online, in the PDF, or the link is down below as well. But this medication is available as a 200 milligram per 2 ml and 500 milligram per 5 ml single dose vials, and it is administered IV. And so that's something that we'll talk about in when you're selecting therapies, or when providers are selecting therapies, why a patient might have one therapy but not another. And you do have to confirm the presence of amyloid beta pathology prior to initiating treatment. So the recommended dosage, as outlined in the package insert, is 10 milligrams per kilogram, and that's diluted and then administered as an IV infusion over approximately 1 hour, and it's administered once every 2 weeks. You do have to obtain a baseline brain MRI prior to initiating treatment, just to make sure that it is safe for the patient. That's one of the monitoring for safety. And then again, you do MRIs prior to the 5th, 7th, and 14th infusion, and you're looking for those ARIAs. And so if there is a radiographically observed ARIA, then there are treatment recommendations based upon the type, severity, and presence of symptoms. There is some more specific information in the prescribing handout about diluting the dose, and it is required. So dilution in 250 mils of is required prior to administration. And then you administer it as an IV infusion over an hour. So this does have to be administered at a hospital or at an infusion center. So that's something that may limit access for patients to receive this therapy. And so thinking about our state specifically and other rural areas, like if we were to end up with agents that were really good choices and people were able to use these routinely in the future, we would need to be able to also administer the medication safely to individuals. And so again, there's more information about specifically how and what to dilute the dose in posted online as well and listed here. So what patients would most benefit from this pharmacotherapy? Well, you do have to have a diagnosis of either mild cognitive impairment or mild dementia due to Alzheimer's disease. And you do have to confirm that amyloid beta pathology. You do have to look at baseline MRI, and you should also have patients tested to see if they have the ApoE for homozygous to determine if they would be at increased risk for ARIA. And so it would be recommended that there's some sort of protocol in place for patients to have counseling before and after genetic testing. And especially they talked about in some articles the ethical issues that are involved with whether you would choose to treat someone or not based on that status, and how you would communicate that to patients and how you would communicate risk to patients. But it is known that having that status does increase your risk for these potentially serious adverse effects. And then what else is important to consider? Certainly the logistics. So we talked a lot about the types of testing that is required for safety and efficacy for monitoring, and then also the administration of the infusion itself. So logistics around that and around being able to get those medications at an infusion center. And then also cost is something that we have to consider as well. And as was posted at the Alzheimer's organization in a news release, quote, the manufacturers of lecanemab announced they are setting the price of the drug at $26,500 a year. So this is a very expensive medication as well. And it does have some coverage as well, but coverage, is certainly dependent for patient upon the insurance that they have and other factors that are in play as well. There is one more monoclonal antibody for Alzheimer's disease that is currently under FDA review. And there was an article that was published in the Journal of the American Medical Association in 2023 that is the Trailblazer Alzheimer 2 clinical trial. And this was a phase 3 trial. The results are published here. This medication is not FDA approved at this time. They submitted their application for approval earlier this year, and I think they anticipated it was going to, that they were going to have a decision by this time, but they don't have a decision yet. So no decision either for or against, but they will be meeting in person to discuss this at the FDA Peripheral and Central Nervous System Drugs Advisory Committee on Monday, June 10th. So in the next month, we may have a decision finally about whether this medication will be approved. And if it is approved, we'll have 2 agents then in this class moving forward. And if it is not approved, then there will still just remain the 1 agent.